Our next presentation today is by Dr. Phil Butler, who's coming on down. He's a physician and geriatrician in Orange Health Service and does some wonderful work around our district. And he's going to be talking about prevention of fractures and ORP clinic perspective. So welcome, Dr. Butler.
Thank you.
Are you welcome for that?
Thanks for the welcome, Ash. I'm sorry I wasn't here for the morning. I've been in Molong for the morning, which is always nice. I thought I'd speak briefly on a small subset of the topic of falls today, something I find interesting because I get to spend Thursday mornings each week in the ORP or osteoporosis refracture prevention clinic. So I thought it might be interesting to see what we're doing here in Orange and talk about some of the challenges we've faced over the last 5 years and what on earth you do in the large part of LHD that doesn't have good access to an ORP clinic. So fractures are just one of several important sequelae of falls. Some sequelae of falls are life-threatening, like intracranial hemorrhage, bleed into the chest or elsewhere, big degloving injuries, dental trauma, long lie, fear of falling, lots of pretty serious things. But fractures would have to be one of the most common serious results of falls. They're so common that there's probably about 50,000 of them each year in New South Wales ACT combined. It's just huge. Some data I've seen suggests that $750,000 is spent on managing those fractures in our state plus ACT alone, so it's hugely expensive. In addition to being expensive, fractures result in additional morbidity and mortality, and a classic example of a fracture that is a marker of increased mortality is a hip fracture, where depending on the study, anywhere from 20 to 25% of people die in the first year after that hip fracture. Other fractures that aren't as well studied are probably associated with increased mortality risk as well. Many of the people who come to our ORP clinic who are otherwise healthy, had something that might seem benign like a wrist fracture, have actually had a pretty miserable time since they had their trip to fracture clinic, surgery, maybe not surgery, maybe a cast. It's not much fun, most people would agree. As well as being an important medical or surgical problem in its own right, there are also a really important red flag. So somebody who's had a minimal trauma fracture, that is a fracture from standing height, they've had a fall for a reason, and it's an important trigger to think, well, why have they had a fall? Is there something we can do about it? Do we have to plan for mitigating risk and adapting to life with falls? And also, they've fallen for a reason, but also the bone is fractured for a reason as well. So you don't need any fancy tests to tell you that someone's bone health is abnormal if they've fallen from standing height and have broken one of the bones that constitutes a minimal trauma fracture. That fracture alone means that those bones are not normal. And that's actually a common area for things to go wrong. People might do other tests like a bone density scan that might suggest things are reassuring, but if you go back to first principles, that bone shouldn't have broken. So whatever the test tells you, there's something going wrong. But despite that being an important red flag, really on a global scale, it's often ignored. So when you think about it, if somebody comes into hospital with a stroke, that's taken very seriously for multiple reasons. They go onto a stroke pathway as an inpatient. The gold standard is stroke unit care, and part of that stroke unit care is working towards a plan for secondary prevention by the time they're discharged. So what medications, plus or minus interventions, are needed to reduce the risk of more strokes? It seems pretty reasonable aim. And I guess same goes for ischemic heart disease and say, for example, STEMIs, there's a STEMI pathway. You're coming for a STEMI, you go on the STEMI pathway, and by the time you get out of hospital, you've got a plan put in place to prevent further acute cardiac events. The same can't be said for minimal trauma fractures. So the experience of many people with a minimal trauma fracture is that there is zero plan in place by the time they leave hospital or at any time afterwards to prevent further fractures, despite that being a chronic health condition that's serious and increases your risk of morbidity or mortality. And that's for lots of different reasons, I think. It's probably part of the problem is that it's managed with, I guess, a orthopedics perspective without inpatient or outpatient medical input. There can be distracting issues. So some of the patients we look after here, like in most hip fracture centres, look after some very unwell, complex patients, and bone health might be issue number 10 after a lot of other competing issues, and we might be doing well just to get that patient out of hospital alive. And so it's very easy for bone health to be forgotten, even though at some point it will become arguably the most important issue. So in Australia, at least, osteoporosis, which I use in the broadest sense, not as a particular result on a bone density scan, but as a disease of bone health that causes fractures, is largely undertreated and ignored. So in a 2009 study, which is a bit old now, of 40,000 people, less than a third of people who had a minimal trauma fracture were receiving osteoporosis treatment. I'm surprised it's that much, actually. I haven't seen any, there is no high quality data for our region, but my anecdotal experience is that it might even be lower than that in this region, particularly away from regional centres like Orange, where there's poor access to general practice, and multiple factors that can contribute to this phenomenon. So in response to this dire state of affairs, a model of care was developed through the ACI close to 15 years ago to address this shortfall. So I won't attempt to explain all of this slide, but essentially the person with a minimal trauma fracture is the middle, and arguably the most important person after them is the fracture liaison coordinator. Their job is to find out who these people are and then to coordinate others involved in their care to come up with a response. And that includes usually a medical officer, admin support, allied health, and the GP. What does ORP look like in Orange? Well, the ORP model that was developed by the ACI really came about based on some tertiary centre models that worked very well, for which there was good evidence that that a patient with a minimal trauma fracture attending ORP clinic had a dramatically reduced risk of having another fracture. I'm not aware of any trials being done in a regional setting. Things are a bit tricky out here, actually. So we're lucky in Orange because we've got a truly multidisciplinary ORP clinic with a physiotherapist, a dietitian, and a doctor. That's not the case in Bathurst, for example, where I think there maybe just be one member of the team, and I'm not aware of a clinic existing in Dubbo, in the northern sector of this LHD. Most ORP clinics would have an endocrinologist or rheumatologist. We don't have a rheumatologist, and for 5 years we didn't have an endocrinologist, and our new endocrinologist, Manik, is very busy looking after mainly complex diabetes management. So I'll give Manik a call if I need help, but I was lucky to have some time in ORP in my training as a geriatrician. We have a weekly clinic here. It goes by pretty quickly, and patients spend roughly 1 to 1.5 hours going through different stations in the clinic. Well, what do we do? There's a screening process that's automated. So everybody that comes through the hospital that has the word fracture in their documentation gets pulled out by the computer, and then that list is screened by the fracture liaison coordinator. Patients are contacted and invited to come to clinic. If they say yes, their GP is updated. If they say no, their GP is updated and asked to follow things up. We used to require patients to come with a GP referral and a DEXA scan and blood tests. It was hopeless. It was just a barrier to good care, actually, because it was all too much. People didn't understand the need before they came here, so they were not really motivated to do stuff around getting all of those things done. So it's working much better now that we bring patients here and then arrange technical investigations if necessary and update GPs along the way. We try and be comprehensive and patient-centred whilst still focusing on bone health and falls. Patients leave the clinic with an exercise plan that's specific for their falls risk and bone health, as well as dietary interventions. A lot of our patients don't leave just with a plan to include more calcium or vitamin D in their and they're up in their diet, but they might be malnourished for other reasons. And so it's an opportunity for some off-target interventions. A lot of my time at the medical station is spent talking about just general principles of bone health education, explaining what a patient's risk of future fractures is, and if appropriate, commencing anti-resorptive medication. They're then followed up and called to make sure that they're tolerating the medication, that things are going okay. It's not uncommon for people to get the heebie-jeebies or read about something and get a bit nervous about starting medication. So that's a good way to catch those people. Patients receiving intravenous zoledronic acid annually are recalled to clinic in a proactive manner. So one thing I use to motivate patients is to just be as objective as possible and explain to people what their risk of more fractures is if we don't do anything. I like to use the Garvin risk calculator because it's reasonably local. It's from Dubbo data. Just as an example, imagine a 62-year-old woman who's fallen once in the last year. She's fit and well. She's had a wrist fracture. She then has a subsequent DEXA scan, which sounded okay because it wasn't osteoporotic range. It was osteopenia. That sort of person would often be told in the community, you're okay, nothing needs to happen. But actually, that person is at very high risk of fractures, and they definitely should be on anti-resorptive therapy if possible. Because if they're not treated, their risk of a hip fracture in the next 10 years is 7%, that's high. And their risk of any old fracture is 27%, also very high. So then I use that to, I guess, explain the rationale for commencing medication, and it's then helpful when they're weighing up pros and cons of side effects, for example. What are the most common medications used? Well, in older patients, above 75, or some younger patients, if their prognosis is not very good, Prolia is a good option. It's usually well tolerated, but requires your vitamin D to be high enough. The main problem is it needs to be given indefinitely and regularly, pretty strictly 6 monthly. Otherwise, if it's stopped, there's an increased risk of vertebral fractures when that happens. And so that requires multiple things to go right. There has to be good access to general practice over a long period of time. It doesn't work well for people in isolated areas who don't have a GP. It doesn't work well for many patients, actually. So a lot of the patients who come to our clinic are a bit younger. I'm not sure why. It's probably there's some sort of selection bias. And so I'm often recommending, rather than Prolia, a bisphosphonate, either oral or intravenous. Many younger patients who don't take any other medications quite like zoledronic acid because it's over and done with, and there's a bit of flexibility about when the next infusion has to be. It's roughly yearly, but if you take the next one in 18 months, it's not the end of the world. There are lots of barriers and challenges to successfully running ORP clinic. Lack of appreciation of the importance of bone health is pretty widespread amongst many highly educated patients, as well as those who aren't highly educated. As I said earlier, some patients have numerous medical problems and are seemingly going to doctors of different types all the time, and so bone health gets deprioritised. Geography is not in our favour. Some comes from Condobolin. To be told you have to go and get a DEXA scan in Orange and then drive 2 hours back and then come to our clinic, and it doesn't really work. So we try and take that into account and make things as simple as possible, and that might mean being pragmatic and not gathering all of the information that we'd like to have in an ideal world. Misinterpretation of investigations, especially bone density scan, is pretty common in the community and can lead to unhelpful advice. And some people are not fearful at all of rare side effects of osteoporosis treatment, but some are incredibly fearful about osteonecrosis of the jaw in general, which is a rare but serious side effect that some people, despite knowing that there are, say, 40% chance of a big fracture in the next 10 years and say 1 in 10,000 risk of osteonecrosis of the jaw, they say, no, I'm freaked out by that. It's not for me. And that's okay, but it's just one of the realities of working in that kind of clinic. Any thoughts or reflections? Or questions?
Questions not completely related to the presentation, but are there any guidelines of screening for bone mineral or testing bone mineral density prior to someone having a fracture?
Yes, there are guidelines, and also, so the question was, what are the guidelines for bone mineral density testing in somebody who hasn't yet had a fracture. Sorry, yeah. So there are Medicare rules about who gets a Medicare-funded DEXA scan, and there are certain age cutoffs that are relevant for that Medicare funding, and there's a mismatch between that and who gets PBS-funded therapy if a patient is osteoporotic, especially in younger people.
There's also a question online. Do you have any thoughts or knowledge regarding the use of FRAX, F-R-A-X, for identifying fracture risk in individuals without the need for a DEXA scan or in the absence of an initial fracture?
So your question was about use of the FRAX calculator. My understanding is that it's very evidence-based. You often get studies I've seen show that if you calculate for the same patient their fracture risk using Garvin and FRAX, you get different answer quite a lot of the time. So you have to take the results of either of those tools with a grain of salt, really. I'm proud to live in Western New South Wales, so that's why I use the Garvin calculator. And I find it's nice to say this is based on local data, and patients live just down the road from it. So that's what I don't use it for any other reason than that, really, and it's just easy to use. Yeah.
The Garvin has a fault, as well as one of the risk factors.
Yes.
That's basically my question. Can you tell us a bit about the cognitive fall component? How's it implemented? And the people here, you've got to actually have people do the exercise and keep doing it.
So there are the question was about what kinds of recommendations are made about falls prevention and how do we know whether people are actually doing what we recommend. So locally, there's one physiotherapy private practice that runs the gold standard of weight-bearing exercises known to, with an evidence base showing that it reduces fractures. That's not available to most of our patients, actually, because of financial constraints. So what is often the case, the focus will be on a home exercise program. All we know about adherence to that is what people tell us in a follow-up phone call. Some people are fantastic at it and many are not. Otherwise, we have very little visibility what goes on here. There's a strong and balanced clinic here, which is a small number of 100% ladies who come to that clinic. And those people do well, but it's a really small proportion of the total patients we see in clinic. So we're really just chipping away at the problem rather than having a truly comprehensive approach. Even doing that has been difficult.